As you'll notice from the title of this presentation, it is treatment of persons with sexual offense histories. A big part of this presentation I hope to offer is dispelling myths, stigma, and shame, which makes it very difficult for people to get help in this department. It makes it difficult for the families that are involved, and obviously, of course, the victims and survivors of these experiences. I, in the spirit of full disclosure, this was not the original title of my presentation. If you got notification earlier on, it was actually treatment of the sex offender. And somebody much wiser than myself pointed out that that is in itself a stigmatizing label. So I've been working for years in this field, and in some sense, I've actually been habituated to a lot of these laws, these labels that we try and get away from in treatment. So I really appreciate that reminder, and I'm going to try and be cognizant of that during this entire process. So I will try and use person-centric language rather than focusing on people's pasts as a way to define them. So let me get into it then. So the first thing is, who is affected by sexual abuse? I felt like I had to put in some statistics just so I could answer any questions if they did come up. But victims are of all ages. For children, it is, by some estimates, 1 in 10 children below the age of 18. Over 90% of children experiencing sexual abuse actually know their abuser, either acquaintances or family members. And only an estimated 12% of child sexual abuse is actually reported to authorities. And unfortunately, that can be because of all the shame and stigma involved for both the individuals and their families. You'll notice that there is far more female individuals who are affected by this. And same as with children, most of these victims knew the person who sexually assaulted them, and also the majority are not reported to police. So you can see from that table, they're predominantly female victims, and for males, it's predominantly in the younger age group for kids. You'll notice that predominantly the relationships of offenders to victims are family members and acquaintances. For juveniles, with a very few comparatively strangers. For adults, there are more stranger relationships, but again, mostly acquaintances. So what are some of the factors related to sexual abuse? As the ages of individuals who do have offense histories shows, most of them are younger. And it makes sense because children or teenagers who are just coming into puberty, they are sexually curious, they're experimenting. I'd imagine we've all been there. And it's natural to experiment, but unfortunately, sometimes people do not know the limits or the boundaries or push them too far. And that's where, again, that's where the ability to talk about a taboo subject really helps, because a lot of people just need the information just to know, okay, what are the boundaries? Now, there are also negative or adverse conditions in early development. This might be their own sexual abuse history or neglect or physical abuse. There is statistics showing that there is a higher percentage of those with sexual abuse histories themselves who go on later to commit their own offenses. Of course, that is correlational. Now, there may also be mental or medical problems. There are a lot of co-occurring disorders in terms of people with impulse control disorders. There might be individuals who are diagnosed with bipolar disorder or schizophrenia. Sometimes traumatic brain injuries result in impulsivity. There are, and there lies the problems with self-regulation and impulse control for a multiple of reasons. Then there are those who purely just lack empathy or concern for others. And this typically is more, you could say, the general criminals who might have more a variety of offenses that typically are used to taking what they want. They might experience some sense of entitlement. These might be individuals who are diagnosed with antisocial personality disorder. Other factors include sexual interest in children, mainly untreated or uncontrolled. And I'll later get into that there is a very difference between pedophilia, for example, and child sexual abuse. They are not synonymous by any means. And then finally, a big factor that we concentrate on in treatment is thinking errors, cognitive distortions that rationalize or justify sexually abusive behavior. And that might be cognitive distortions that enable it in the first place and also sometimes justify it after the fact, kind of protecting these individuals' egos. Okay, so different offense types and different people by those offense types. Typically, those who have offended against children inside the family have few victims in multiple occurrences, which makes sense based upon them having access over a longer period of time. And they have the lowest recidivism rates because oftentimes once discovered, obviously they are taken out of that home. They also may not necessarily have sexual interest in children exclusively. It may be related to other factors. Extra familial offenses, however, are more likely to have a deviant sexual preference because they're taking steps outside of the norm to go out and find people who are more susceptible. And those with male victims do have the highest rate of recidivism. Typically, even though it's they are the minority, they also offend most often, unfortunately, or at a higher rate, statistically. For those who have offended with rape are often more similar to general criminals and more prone towards an antisocial lifestyle. So they'll typically have a lot more of a criminal history, a variety of different crimes, and they might need to work on other just general self-regulation things and attitude problems or thinking errors. And then finally, there are non-contact offenses, which do tend to be more compulsive and have multiple offenses and victims. So this might be indecent exposure. Typically, individuals do have a long history of multiple exposure incidents, or voyeurism or frotteurism, either viewing people or rubbing up against. Additionally, also child pornography, or how I'll refer to it henceforth is child exploitation materials. A lot of people do not may compulsively view this because they might view it as a sense of coping. It might be a compulsive type of behavior. So let's get into how we measure rates of recidivism or risk of recidivism. So the static 99R is used as the main instrument in the criminal justice system to determine how likely individuals released from prison on these offenses are to commit an offense in the future. And these are the factors that are measured. So again, as mentioned before, age is a huge factor. So you can see from that graph there that those who are 24 ages or younger are almost twice as likely to recidivate than those 40 or older. So the age at release is a big factor in determining their level of risk. Additionally, whether they've ever lived with an intimate partner for 2 years shows a sense of stability and ability to attach to adults and to have appropriate connections with others. Other factors linked to risk are: was there any violence involved in the offense itself? Do they have a history of violence before that? Do they have prior sexual offenses, charges, or convictions? Do they have a general criminal history that is in excess? And then the other things that are typically less common, but do show higher rate of recidivism or repeat offending, is non-contact sexual offense conviction. So again, something like indecent exposure is shown to be more compulsive. Any unrelated victim, any stranger victims, and then any male victims, all increasing risk. Now, in addition to the static, which only measures historical factors, the stable 2007 was developed to measure more dynamic factors. So although they are changeable, they are stable generally. So over a longer period of time, they might need to work on these things like self-regulation, like intimacy needs. They don't change overnight, but they are changeable. So this is developed not just to assess recidivism and intermediate risk, but also to assess treatment needs. These factors can actually be changeable. So if we focus on them in treatment, we can actually shift their risk in the community. So the general factors assessed may be their social network. So how many positive and pro-social influences do they have around them? People who are in support of them, who want them to do well. And then on the other hand, how many negative or pro-criminal or pro-deviant sexual interest individuals do they have around them that might influence them in the opposite direction? Because we are social animals after all. Now, intimacy deficits is a huge factor. How well are these individuals able to relate to others? Adults and partners, women in general, and then their ability to self-regulate, both generally and sexually, is a huge factor. And then their cooperation. Generally, those who are supervised in the community, a factor that is assessed is how willing are they to work with their supervisor with treatment. How willing are they to be open and make sacrifices to avoid high-risk situations? Because that is a big part of treatment, is identifying, okay, in a behavior chain of what led to what are you willing to give up so this doesn't happen again? All right, so in terms of intimacy deficits, some factors include their capacity for relationship stability, which was actually included on the static, so that is a common factor. And it's a protective factor, right? Rather than a risk factor, if they're able to show some stability, then it protects them against that risk. Hostility toward women is a big factor if they have deficits in their capacity to form warm and trusting relationships. If somebody has more sexist attitudes, entitlement, that can put them at risk of harming. Then there is general social isolation, rejection, and loneliness. How capable are they of making friends, feeling close to others, having a secure adult attachment? This doesn't include people who are just introverts. Some people are kind of loners and they're happy that way, but people who really do feel isolated. And we'll get into later how some of the laws and regulations surrounding how we treat these individuals can unfortunately contribute to that. Then there is the lack of concern for others. Again, do they have empathy for others? Are they able to make sacrifices for the greater good for people they love? or do they just act in their own interest? And finally, in terms of intimacy deficits, there's emotional identification with children. And this is specifically for those who have a offense history involving a child, because some individuals may feel that they are on their peers or equals kind of more comfortable relating to children than to adults, which puts them more at risk. They may have more interests that kind of correlate with children, whether it be children's TV shows or games, dressing, the like, which can also kind of attract as well. And then there is general self-regulation as a factor that we look at. How impulsive are they? Do they easily bore? Do they seek thrills? Do they not think of the consequences before they act? In a multiple variety of ways, not just sexually acting out, but in other ways as well. Even just driving fast and not thinking about the consequences. It just shows that somebody has that impulsivity, which is can carry over to other areas. Poor cognitive problem-solving skills can be a factor if they're not able to challenge, if they're not able to identify problems, generate solutions, and evaluate alternatives to avoid risks. A big part of treatment that we constantly go through is what we call risky bets. So high-risk behaviors, emotions, thoughts, and situations. And we go over them quite regularly because just about anything could be determined a risk in the wrong situation, with the wrong emotion, with the wrong thought. So a big part is just developing that skill to be able to evaluate, okay, what's going to happen if I do that? Do I really want that? Can I look at the consequences and change my behavior? Or avoid putting myself in the situation to begin with? Is a big part. Now, negative emotionality and hostility is a factor, because some may ruminate on past negative events. They might feel victimized and resentful, feel overwhelmed, and because of that, act out. So sometimes we address what we call grievance thinking. How often or consistently are they expressing grievances towards others, the system, sometimes the victim themselves, where they blame others for their own behavior? And in addition to general, there's also sexual self-regulation. So how preoccupied are they with sex? How high is their libido? Do they masturbate excessively, engage in promiscuous sex, view and collect pornography? They might describe having intrusive thoughts and impulses. So sometimes they don't choose to, it just happens to them, and it may interfere with pro-social goals. They may very well want to reduce their preoccupation. Because it shows that the more sexually aroused you are, preoccupied, sometimes it just puts you in that frame of mind. So regardless of which situation you're in, you're slightly more apt to sexually act out. Some may use sex as a coping tool. Their sexual thoughts or behaviors are used to cope with stress, and they might use it to self-soothe negative emotions like anger or frustration. And that might be acting out or viewing pornography. And finally, deviant sexual interest is a factor with when those are sexually interested in people, objects, or activities that are illegal, inappropriate, or just highly unusual. Deviant in the sense of being outside the norm. So now we get to pedophilia, or sexual interest in children. I feel like this is important to note because there are individuals that would meet the diagnosis for a pedophilic disorder based upon the DSM. And that would be having recurrent, intense, sexually arousing fantasies, urges, or behaviors directed towards a prepubescent child over a period of 6 months, at least. If there is a victim, if they have to be at least 16 years old, and if there is a victim, they have to at least be 5 years older than that child victim. Now, part of the criteria is to have acted on these urges or be distressed by them. I wanted to emphasize that because not every individual diagnosed with pedophilia has had a victim. Some are distressed by the urges and fantasies that they have. So pedophilia does consist of sexual interest in children, but it doesn't necessarily lead to child sexual abuse. And not all individuals who have sexually assaulted children have pedophilic sexual interest. There are cases of people who it's based upon other factors, whether it be using the child as a surrogate for a relationship that's not going well, and other reasons. And having an exclusive interest in children puts someone obviously at higher risk. Exclusivity means that they are purely only interested in a prepubescent child. And that doesn't allow them the opportunity to have a healthy and satisfying sexual relationship with an adult. So that is a factor that we assess as well. And that leads to shame. Imagine having these intense sexual urges and fantasies. Individuals do not choose to have these. It ordinarily develops in adolescence or even earlier, much like other sexual interests, and can be very difficult to talk about because sex is difficult to talk about as it is, and then any kind of taboo makes it increasingly difficult. Shame, of course, is an emotion central to sexual abuse. The victims of sexual abuse may feel ashamed because they have participated in taboo activities and often maintain secrecy. They may have been groomed to maintain secrecy, told or threatened that something would happen if they didn't maintain secrets. But that does compound the shame, not being able to talk about it. They may result in strained relationships in families. The individuals who maybe feel like they failed to protect the child, or confusion about who is to blame. And victims may be shamed by statements made by the offender to try to convince them that they themselves provoked the abuse. And that leads to some of the cognitive distortions that I was talking about. Sometimes they may say that, for example, let's say a child simply sitting on the lap is innocent in and of itself, but can easily be twisted in with the wrong statements. And victims may be accused of being flirtatious or seductive or asking for it. So that's typically more common in adult victims. And there's this cultural myth that men cannot control their sexual impulses. So sometimes there is this focus on the female victim of being responsible for some reason, and sometimes that is an effort of the family or the man himself trying to protect the ego, because these cognitive distortions do protect the offender's ego, but they do further accuse the victim. So a big part of treatment is trying to target that blaming the victim and seeing if they can come around to that truth. So some statistics of those that have been released from prison with histories of sexual offenses. So from this study, within 98% were male, and that is consistent with the individuals I work with are purely male. We do have some females, but other clinicians see them, so it's a huge minority. And based upon this table, you can see the statistics of individuals that were released. Those with sexual offenses were more likely to receive longer sentences, and therefore they were also going to be older at release than individuals with other offenses, a median of 38 years versus 34 for others. They are more likely to be arrested for rape or a sexual assault. Just like any offense, they typically are going to be more likely to offend in the same area. However, they do have a lower general rate of recidivism. So based upon that table on the left, you can see compared to property, drug, public order, and all violent offenses, those who had a history of rape or sexual assault actually recidivated at the lowest rate of about 67% generally, compared to about 84% for all others. And also on the table, you'll notice that those with a history of sexual assault also have fewer arrests in their history. So what about after treatment? So they have done some studies to show that treatment has had an effect of reducing both sexual and general recidivism by about 26%. So sexual recidivism typically is lower than general recidivism, and both are reduced. Cognitive behavioral therapy has been shown to show the most significant reduction in sexual recidivism, and it helps in that it is a very manualized treatment. It's very psychoeducational. So regardless of how motivated the individual is, they can still absorb a lot of this information. We also do have a lot of group therapy. So there is the opportunity to learn from others based upon their mistakes and what they've identified. Okay, I need to avoid this situation because it's going to put me at risk of acting out here. So cognitive behavioral therapy really works pretty well. Now, has been shown to be some different treatment effects depending on how intensive the treatment is. Now, larger treatment effects were found for higher risk persons. So again, that risk is based upon the static 99 risk instrument I described earlier. So somebody who has a whole history like that shows that they're a higher risk, if they receive intensive treatment services, their rate of recidivism has been shown to decrease. So to a general recidivism rate of 32% versus 51% without treatment. However, what's interesting is that those who are lower risk, so they don't meet all those criteria to be high risk. They don't have an extensive history. They might not be young, they might be older, and it'd be more of a situational offense, for example. And if they were to receive intensive level of services, their recidivism rate was actually shown to increase. So 32 versus 15% without or with minimal levels of treatment. And the reason I believe that is because people do not like being labeled. I know I don't. And typically people want to move past their pasts. And sometimes if we are constantly reminded of that and we're fitting people in a box and being very clear about our expectations, sometimes people fulfill those expectations. So sometimes I like to think about it in terms of the Rosenthal effect or the Pygmalion effect. A lot of you might be familiar with the study by Rosenthal and Jacobson, where they studied children in a school environment, and teachers were prepped to believe that a certain subset of the class were going to be bloomers. They were going to excel. Of course, they were picked at random. But after a period of time, they actually did perform better, showing that how they were treated and how they're expected to perform really had an effect on how they did perform. In terms of criminal justice, this has been described in Heckler's causal chain, where being held in low self-esteem makes so that other people anticipate deviance from those low esteemed persons. Then they perceive that others perceive that of them. They then perceive themselves as deviant. It becomes part of their self-perception. Then they search for roles that are consistent with that role of being deviant, and then they adopt it and accept. Basically, there's no turning back now without somehow breaking that chain, somehow along that line telling them, hold on, past is the past, let's move on. And now, so let's get into some of the laws that are involved. So registration and notification. Some of you may be familiar with what's called Penal Code 290 sex offender registration. And then there's also community notification laws in some areas where the registration, individuals with a sexual offense history will have to register with their local police department. Anytime they move, for homeless individuals, they have to register every 30 days. For those who do have residences, it's once a year. And it's very difficult for some of these individuals just to remember to file these. And depending on which area and county you're in or state, these registration laws are going to be different. So unfortunately, they've got to really keep on top of how many days to register, when to register, so that they don't end up with a failure to register, which unfortunately is oftentimes the reason why a lot of people go back into custody and then return to treatment, is they've forgotten to register for whatever reason. So some statistics have shown community notification did not appear to reduce recidivism for identified registrants. And studies have shown that those who failed to register are no more likely to sexually recidivate. So, and I have the example of there are individuals that simply just cannot remember. They might have brain injuries, or they might have dementia. They might have substance use disorders, which dysregulate them. So that is a huge factor. And most sexual offenses are committed by first-time offenders who know their victim to begin with. Now, registration, unfortunately, has deleterious effects on these individuals: physical harassment, assault, job loss, loss of housing, their families themselves being harassed, and of course, lots of negative psychological consequences of always having to carry this label with them. And then, of course, registration is also costly, time-consuming, and resource-intensive. What's good is that there are efforts to change this. So in California, for example, they have entered a bill, I believe beginning next year, to change the current lifetime registration to a tiered system where, depending on the individual's offense history, they might fall into 10-year registration, 20-year, or lifetime for the more serious or at-risk cases. Now, in some areas, they have a system called Circles of Support and Accountability, or COSA for short. And it's a supervision strategy involving the use of community volunteers to provide support to a core member. This is what they call the individual. And it assists ex-offenders in garnering community resources, holding them accountable to their self-monitoring plan. So we have a similar system here, except it doesn't involve as much of a community volunteer and positive building approach. This was first developed in Canada, but has since been implemented all over. And research has shown some evidence of general recidivism reduction, but more importantly, demonstrated more harm reduction, with subsequent offenses being less severe than the index of offense itself. There'd be less sexual or violent offenses and more contact, non-contact, and supervision-related offenses. And there's always going to be supervision-related offenses because these are individuals that do have impulsivity, self-regulation problems, and a whole host of other things that can lead them to just make mistakes. And a lot of times that is what it is just being in the wrong place, making other mistakes, not necessarily related to their sexual offenses. And studies have shown that offense-based labels associated with less willingness to volunteer, with the most pronounced being sex offender. And that's why one of the reasons, it's great that they use core member. Because if you want people to volunteer from the community to be supports to these individuals, to rehabilitate, to reintegrate, we want to treat them as such that they are attempting to be pro-social members of society and not being labeled by their past. So some other specific treatment techniques that might be important. So, of course, first and foremost, informed consent is important for all treatment, but especially for this group because they need to be aware of mandatory reporting laws. This is, of course, a big part of why many decline to participate in treatment to begin with, why they cannot be entirely open about what they talk about. So being very clear about what's okay to talk about and what's not okay is really important so that they can at least get treatment. Of course, acceptance is huge. Developing a therapeutic relationship with this individual with unconditional positive regard, like Carl Rogers always said. And it can be a challenge, and we have to check our countertransference at the door and recognize that a lot of people are harming because they themselves are harmed, or they may very well need help. They may benefit from just normalizing the experience. For somebody who does have an attraction to children, destigmatizing that. Obviously not giving any kind of approval, but letting them know they're not alone. There are other individuals who have had that same experience, and they were able to cope through a variety of different ways. Motivational interviewing is used extensively, just discussing, okay, well, what's it going to be like if we change this? Why engage in this in the first place? If they can identify what's good about it, what's bad about it, they can come to a conclusion for themselves. Most people don't like to be told what to do, what not to do. So just discussing it in a way that they come to their own conclusion, knowing what's best for them, as well as the people they love. So it's similar to how one might engage treatment with somebody who is addicted to anything. You can't just tell somebody to change, they have to come to the change themselves. And another factor that's important is life skills training, teaching just basic social skills, emphasizing adult romantic and non-romantic relationships and appropriate behavior with children. I've worked with developmentally delayed individuals who really just don't understand until they really go through it layer by layer, step by step, what is okay, what is not okay, good touch, bad touch. There is relapse prevention efforts where the idea is for the person to gain insight into their own cycle of abuse so they can figure out, okay, what led to what, so that they can step in earlier to avoid, for example, let's say being around children unsupervised, just knowing that that is a risk factor for them, just knowing that their own ability to self-regulate is limited. Sometimes just accepting that and doing what you need to in order to protect yourself. Other co-occurring disorders obviously need to be treated. So substance use disorders, mood disorders, ADHD, neuropsychological conditions, anything that's affecting their executive functioning and their impulsivity is important to treat. And medication is used by some. Selective serotonin reuptake inhibitors, although primarily for depression, do have a side effect of lowering libido. So there are some individuals who take it for that, so they don't have to be tormented sometimes by these urges that they did not necessarily choose. And anti-androgens are a medication that reduce their testosterone and thereby their sexual drive. But they do have a lot of side effects, and there's a lot of stigma involved with that, with the chemical castration kind of movement. So these are some of the techniques involved. And finally, I thought I should touch on preventative treatment. The ideal would be that people would seek treatment before they acted out, of course. So undetected persons viewing child exploitation materials are unlikely to seek help given the severe stigma. I can't imagine anybody would feel comfortable coming out and letting somebody know about their proclivities, their interests. And it is likely to be inhibited by mandatory reporting requirements, especially if they're not clear about what they can report and what they can't. So I would urge you to be very, very familiar with your own mandatory reporting requirements and sharing that with them. For example, that you would have to report any kind of child sexual abuse or child exploitation, so just viewing or downloading that material. And some online resources have popped up which are great. Stop It Now, Help Wanted, and Troubled Desire are just some of the examples of websites that have been created so that people can get help anonymously, confidentiality. And what's interesting is in Germany, in Berlin, there's a project called Dunkelfeld, and they offered treatment to those who did have sexual interest in children. And they recruited their participants through a mass media campaign where they had billboards, they had television adverts, basically saying, if you're having these feelings, come in and talk to us. And why they're able to do that is they don't have mandatory reporting laws and requirements. So those individuals are able to go in there and talk about their past openly. And in their study of these participants, it showed that they did show improvement in sexual self-regulation, emotional problems, and offense supportive attitudes and beliefs. Examples of which would be, it is okay, for example, to engage in sexual activity with a child. Some people have these beliefs that facilitate that kind of behavior. Even example of the NAMBLA, the organization that promotes man and boy love, is an example of one of those. So that is essentially everything I had for you. I wanted to just leave some of the references there. I know that they're going to put this video up online, so thought I'd just pop that up. The numbers refer to the pages before this. And if anybody has any additional questions, please don't hesitate to reach out and let me know. Also, any feedback. If I was wrong about anything in here, I'd love to hear it because I'm still learning a huge amount about all of this. So I'm always open to hear other ideas. And finally, there is my email address. So please do go ahead and email me if you have any questions. So now I'm going to go to the question and answer. So somebody just asked the question, what is your take on the idea that pedophilia is a sexual orientation? I probably shouldn't answer that one because that is a hot topic. I can't say that I have an opinion because I just do not have enough information on that. I haven't done enough research on that. But there are, I'd rather not use the term sexual orientation because I think that should be referred to appropriate sexual interests, right? Somebody has a sexual orientation involving their same sex or the opposite sex, absolutely acceptable. As soon as it's a sexual interest that's outside of legal or predominantly legal, but also socially accepted norms, and there is shown to be harm resulting from that, I don't think you can necessarily call it a sexual orientation, but just a sexual interest. So I hope that answers that one. So somebody asked about the gender breakdown of clients I see. I 100% see male clients at my community clinic, Orange Psychological Services. There are some female clients, but they are an extreme minority, and I don't see them myself. So we have a treatment team, so other people do specialize working with females with sexual offense histories who are different. Obviously, they have different factors that relate to their own offenses. Some of the actual instruments that we use to establish risk are not normed at all on females, so we cannot use them. So they have to use other ways of determining risk and working through those things. Let's see, I think somebody asked, is the slide suggesting that minorities, lower class, and underprivileged are more likely to be offenders? I should have been more specific that Heckler's causal chain, I adopted because I thought it was kind of instrumental in understanding how somebody's expectancies can be influenced, particularly towards a deviant path. But that theory was established decades ago, and probably at a time where it wasn't as appropriate. So I purely want to say that that was purely intended for those, in a theoretical sense, those with sexual offense histories, and not related to minorities, lower class, or underprivileged at all. Do I recommend that sex offenders participate in 12-step groups such as SA or SAA, or is this a problem better suited for group work that is specific to persons with sex offense histories alone? I'd say one is not better than the other. I think it would depend specifically on how that person identifies. So if they find that they do have a sexual addiction that they want to work on, then a 12-step group would be absolutely great because they would get support in that department, other people that understand. If it's not as much related to an addiction, but more specifically to, for example, deviant sexual interests, then that specific type of group would be better. And some of those resources I shared earlier for voluntary treatment, there are some online groups that are available to individuals to seek out support from other people who might understand. Question having to do with ideas about restorative justice versus retributive justice and relating to offending behavior. So restorative justice is ideally seeking to repair the community, right? Repair for the victim, for the family, for the offender, all involved, to come to some sort of closure, rather than simply just retributive justice, which is just punishment, which ultimately doesn't help anybody. The idea perhaps would be to prevent, in a sense, that other people be warned against it. But oftentimes, as I've discussed, this comes from general lack of self-regulation or sexual interests that one did not choose, or a lot of reasons that people were not necessarily thinking about the consequences of their actions. So they may not be, put off by that. But if you come from a restorative justice standpoint, there is a lot of room there for growth and repair. There are some individuals who have had the opportunity to come together and talk about their experiences after the fact, to actually come to understand, okay, what was happening in this person with a sexual abuse histories background that led to this behavior. Not in a sense that any of it is excused, but to understand and forgive. So another question, for the preventative treatment lines, it is confidential. What do they do? Refer to the treatment. So for the confidential online treatment, basically they do not take any identifying information. So from, I think each line and web page is different, but they might be able to purely take some demographic information. They say that they don't collect IP addresses, for example, and that allows it to be confidential as long as they don't actually share information that they might have to report. But they are still able to work on actual treatment. Okay, so somebody asked, how do you navigate mandated reporting laws and processing with or treating clients in therapy? And I'll say very difficultly. Unfortunately, I've got to constantly remind clients of where that barrier is. If they're, kind of preparing to talk to something that I know might put them at risk, I do remind them. Because sometimes you're in the midst of talking and processing things and things come up. So ordinarily we start by talking about the actual offense that got them into treatment, but sometimes they are unreported victims from the past. So if that is the case, we tell them very explicitly, okay, it's important that you're open about this, but at the same time, I do have to report if you tell me any identifying information about these individuals. And then, of course, I'd have to report if that was the case. Okay, and somebody said, just to clarify, sex addiction is different than sex offending. SA is consensual, sex offending is not. SA or SAA is not appropriate for sex offenders. So thank you, Anonymous, for clarifying that. I very much appreciate that. Let me finish with this question. Somebody asked, how did I get interested in this field? For me, it was purely, it began as a curiosity. And for over the years that I have worked with them, I actually love working with this population because it is so multifaceted and different. Even though I only work with men, they're all very different, come from all different backgrounds. So it did come initially just from interest. I'm a clinical psychologist predominantly. I didn't train as a forensic psychologist, so I feel like I take more of a clinical angle than forensic. And I do enjoy working with what I consider kind of an underprivileged, underrepresented population. So, or in terms of empathy at least. So to be able to offer that, lead by example, right? And on that note, I think I don't have enough time to get to everyone else. So again, please email me if you do have a specific question and I'd love to answer it. And thank you so much and have a great afternoon.